Good afternoon, everybody, or good evening, or in the middle of the morning down under, wherever you are across the globe. It's great to be with you on this Friday, May 20th, 2022. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. But on these Fridays, and it's been a lot of Fridays, this is number 92. I'm here on behalf of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, for which I have had the privilege of serving as the president of the board for many years now. And so on behalf of the SADS Foundation CEO, Alice, Laura, and all of us at the SADS Foundation, thanks for joining today. Thanks for being part of SADS Live. Thanks for your partnership with us. As you know, we are an organization, a nonprofit advocacy organization devoted to families with genetic heart diseases like long QT syndrome, Brugada, CPVT, and arrhythmogenic cardiomyopathy. And this month, we've been doing CPVT Awareness Month. C, catecholaminergic, P, polymorphic, V, ventricular, T, tachycardia. Catecholaminergic, polymorphic, ventricular tachycardia, CPVT Awareness Month. And yes, we're still in the pandemic. I guess it's now endemic. So still remember to do the things. I've got my SADS Foundation mask. I wear it when it makes sense. Full disclosure, I never wear it alone in the car. I wash my hands. I'm vaccinated. I'm boosted. I'm crushed. So that was January. My wife's fault. She gave it to us. So do all the right things the best you can when you can as we navigate our way sort of through the pandemic, and strain variants will come and go. There'll be new spikes. The numbers are starting to rise again right now. So yes, we still are COVID-19. We think of that because this program, SADS Live, across many social media platforms now, was birthed in February, March 2020 because of the pandemic. And now we're at episode 92. And so I'm really excited about this one. I've been looking forward to it. It's been on my calendar marked because of the guest, Dr. Shubhayan Sanatani from BC Children's Hospital up north, northwest, over that way. But Shu is a dear friend of mine. He's one of my favorites. So we won't tell anybody out there. And Aaron is going to bring one of my all-time most favorite individuals, somebody who I just like a lot, respect a lot, and we've grown up together in the field. So Aaron, if you'll bring Dr. Shubhayan Sanatani up, and here's Shu. So welcome to SADS Live, Shu.
Oh, thank you so much, Mike, and thanks for having me. We really have grown up together. I remember the first time, the only time I was at the Mayo Clinic was back in the 90s, and you were doing groundbreaking stuff on long QT and, doing work with Coburn Porter. And, a lot of people make a bit of a likeness between long QT and CPVT. So great to be here focusing on the lesser known of the two.
Well, I know, Shu, your titles, you're chief of the Division of Pediatric Cardiology at British Columbia Children's Hospital, you're professor of pediatrics. But before we get to how you got to those titles, I think everybody would love to hear your journey of your career path and how things unfolded, and how the particular passion in CPVT came about.
Well, I owe a lot of gratitude to mentors along the way. As you and I know, there's so many wonderful people in our field at all levels, not just physicians, researchers, scientists, nurses, and parents and parent families. So I did my medical school out here in Vancouver and did pediatrics in Ontario. And then I came back to do pediatric cardiology. And one of my first mentors in that field was John Smythe, who's what I call a plumber. He's a ultrasound doc, but he set me on my way. And then I spent time with Robert Hamilton, and I know you've had him on this show. And Bob Hamilton has done a lot of work in the inherited heart rhythm field. He's really, he inspired me. One of the most difficult and memorable cases during my fellowship was a CPVT case, and it was a tragic story of a teenager who had gone off their medication and was in a cardiac arrest situation and out in the periphery, and talking through paramedics, on a almost impossible situation, still with me today. And, and today, some, X number of decades later, that story is with me. And I tell you, no word of a lie. We have had the exact same story repeat itself this week. So it's still out there. And so I have
fascinating, isn't it? How the stories often are birthed with one of those never forget encounters with a patient early on. Mine happened exactly the same with an admission of a 10-year-old boy with a near drowning back in 1996. So all of us, I think, we trace it back to sort of a pretty profound story that grabbed us in a pretty impressive way.
Absolutely. And then a little bit later on, I came to meet really wonderful basic scientists. I was new in my job here, and I wanted to see how I could contribute to electrophysiology in a more meaningful manner, or in a meaningful manner. The people sent me across the street to what I call my calcium guy, Glenn Tibbetts. And he is, he's a world expert on calcium channels. And back then we wrestled a little just with a common arrhythmia, post-operative arrhythmia, junctional tachycardia. But eventually we got a bit more sophisticated and really have gotten into the world of CPVT, and have done some exploratory work in stem cells. And it's really been a journey. Talk about, long relationships, you and I, and, Glenn and I have been collaborating for, 20 years.
Wow.
And it's those kind of people, and, and realizing that those type of scientists, they are so eager to help us. And, and the treatments we use are somewhat archaic sometimes. You've written about this yourself. If you have a hammer, we use if everything's a nail. So and so Glenn Tibbetts is very dedicated to refining our treatment. So that really got me pointed in the direction of, well, let's pull together on this CPVT work, and get more people to share their cases and collaborate.
And I'm thinking of, and I'm going to come to the collaboration in just a bit. But when I think about that initial story of yours, and now we've been hearing and doing and taking care of stories for 20 years, clinically, as you've seen the past 20 years, what still frustrates the daylights out of you when you hear some of the stories, and as you see the different ways that CPVT is caught, or frankly failed to be caught? We are in CPVT Awareness Month, and I'm just curious, from up there, are there particular frustration points that you say, my goodness, it's been 2 decades and this story is still happening? You mentioned you have a story this week. So what frustrates the Dr. Sanatani about CPVT right now?
Well, I think the first frustration is the awareness piece. And, to your point, this is the awareness month. There's sort of what feels like an inner circle of people that understand when fainting is not fainting. And fainting is such a common problem, probably affects, a third of our young, healthy people. But that ability to sniff out the faint that needs the urgent referral, And the urgent referral has to be to someone that knows what they're talking about. And I sound kind of, a bit high and mighty, and it's not to take away from any of the frontline people. They're doing an amazing job, especially,
Right.
they've been saving our butts these last 3 years.
Right.
But, you know, how do you get the kid that has a faint during swimming class, or that keeps fainting in an unusual fashion? So, I'm a little bit late for class and I'm running to class and I faint. So how do we get the med students to hear that story and store it somewhere, so that when they're the family doc or the emerge attending, they know, okay, this goes straight to and not even just the EP service, not just the electrophysiologist, the electrophysiology service, but the actual inherited heart rhythm team.
Right.
Because there are even within our team, there are nuances about these conditions that are, CPVT, I think, is one of the most nuanced. So I think the awareness piece, we still have work to do. And then, of course, this, the science as well. But I don't find the science frustrating per se. I think, everybody's working on that. I think we really are rowing together internationally. But how do we avoid these, 1-2 year delays in diagnosis or mislabels?
So how do we do that, do you think, Shu? Because I would say that's probably my single biggest frustration too, is when I see the stories and I just shake my head. And like you said, you don't want to be, the Monday morning quarterback, but I think many of these are not Monday morning quarterback, but are so flagrant fouls of disrespect or failure to respect or activate that exercise associated faint needs to be put into the penalty box. And I just see a total lack of urgency. We've done a good job, I would say, in a fairly short time of taking Friday night concussions at football games, and the kid gets put into the penalty box until they get concussion cleared. And yet we don't seem to assign any urgency to the exercise faint. I mean, even when the front lines is bothered by that faint, it's as if, oh, go see a heart doctor sometime. And I just wonder, you and I have been trying on the advocacy front for 20 years. SADS Foundation has been trying. It feels to me like we're not doing something right, because we should be making way more progress on this front. Or am I being too hard on ourselves? I just find this so frustrating.
Well, I mean, you don't get to be Mike Ackerman without being hard on yourself. So, you push yourself hard and you hold high standards for all of us, and bravo. You and I are our bandwidth, we're reaching, I mean, you're reaching a lot more people than most, but our collective voice is still pretty small. When you look through the curriculum at the local pediatric, conference, it's focusing on, the asthmatic and the, all these other conditions. So it's how do you get them to really to notice the needle in the haystack, or prioritize that? So that's tricky. I don't know that I'm always delighted when a family comes forward with their story. I think they're a very powerful voice. We have some, it's often the mom, but it could be any family member. When they come and tell their story, I think people listen also, and mobilizing those parents that are concerned and say, well, my faint doesn't seem, something's not sitting right with me. So empowering those families is good. Now, again, 1 in 3 people faints. No one can handle an onslaught of every fainter, and that's not necessary. But how do we continue to simplify the message that, exercise and swimming faints must be seen by inherited specialists,
and must have a treadmill stress test. I think that's the other thing. And in fact, on the question, the sidebar, thanks, Evie. The timing was perfect for your question. She's asking, what is the best method of diagnosing CPVT? And I think that's where, is another pain point, if you will, is even when we get somebody to be annoyed about the faint enough to do something, the do something is usually an ECG and stop. And yet for CPVT, the message to me has to be anybody who faints suddenly, unexpectedly during exercise activity, swimming, must have a treadmill stress test, full stop. No exceptions. And it needs to be done pronto, not when we get around to it. So maybe unpack for Evie a little bit. What is your evaluation when you are referred a patient for CPVT? And how do you make the diagnosis of CPVT?
The referral usually comes without enough information. You get a note, syncope with exertion. And I do prioritize those, but so many of those are, the kid, especially this time of year, it's track season. They've been sitting indoors all year, and suddenly they're out there just giving her on the track. They run a 400 and they stop, they puke, and they faint. That's very different. But the referral says the same thing. So you've got to rely on, your triage person. But, and I'm old fashioned. So I still think that you're going to smell some smoke with a good history. There's going to be something that doesn't sit right. And, it's the learning that history and taking time. I must say, most of the medical students that come through, and by the time they come to us, they're in their third or fourth year, they haven't necessarily learned how to take a very good fainting history. So we've tried to simplify that. We've put out articles and there's tables and that. So the history is going to give the clues. We've done exactly as you say. They're going to get an ECG, and their heart rate might be a bit slow, but the ECG will usually pass as normal. And the echo, which the echo gets done on everybody, that's also not contributory. So did you listen closely enough to pick up on the cue that says he or she must have a treadmill? Now, if they're 4 years old, then you can do a Holter monitor and say, send them to the playground or a birthday party or something.
Yeah.
But yeah, and we've just put out some very preliminary information that maybe even the standard treadmill isn't going to pick up everybody. Now, we've applied this in some of our known CPVT cases, but when we get them to sprint, we actually pick up, our diagnostic pickup improves. And that makes sense, because a lot of these youngsters, they've been out there, they've been doing stuff, they've done their athletics, some of them are on teams, but they present usually with a unanticipated adrenaline, or adrenaline that caught them off guard. So that, a sudden fright or an emotional faint, so things like that. So you really have to learn to listen to those cues.
Yeah, and I find, like just this week, you mentioned you have somebody this week, last week we had somebody where the delay from first suspicious symptom, which you and I would look at that and say that was a stress test worthy symptom, to correct diagnosis was 18 years. And then now this week, we had a young child who had 5 faints. And so now the correct diagnosis gets made after the 5th faint, but they're already implanted with the defibrillator, and the family are under the notion that this is really aggressive CPVT, because look, they fainted 5 times. And this was 5 times over the span of 3 years. And my mindset has been, no, it may not even be high risk CPVT, because if that first faint would have been respected, evaluated, diagnosed, and treated with simple treatments, there may well not be faint number 2, 3, 4, and 5, creating this impression that the substrate is bad in their body. And so, like you said, to help the front lines activate things with the first suspicious faint, not waiting till the 5th one before they finally send them to cardiology, or in this case, the patient was under pediatric cardiology care and then finally got sent to the electricians to get their first stress test 3 years later. And I'm just curious, are you encountering that at a rate that's, well, maybe not at the rate I am because you have more hair than I do, but I used to have a head full of hair until all of these cases.
You raised a lot of touch points there. The I I I agree that it's, you sometimes get lucky and the first faint will be enough to catch someone's attention, but that's the exception rather than the rule. So they come in and they've had a number of faints. But I agree that doesn't necessarily mean you have malignant CPVT. And then the person that puts in the defibrillator who's convinced you that this is necessary has also set this, this label of severe CPVT. So you need a box. And you and I have both, talked about this. A defibrillator is not needed in the vast majority of well-managed CPVT patients.
Mm-hmm.
So the defibrillator probably is reserved for some who are, truly the tip of the iceberg. But, how do you, let's say you have the 5 faints, once you're on the right treatment, you usually do very well. And that's the good news is, once you get the correct diagnosis and the correct treatment and you're compliant with the treatment, right. Life actually gets very good. So I pride myself here when I met this family this week, I said, all of our CPVT kids are attending school. They are active in whatever recreational activities they choose. And only, I would say here, 10 to 15% of them have defibrillators. Mm-hmm. So, just backtracking a little bit, I was discouraged when I read one of the publications that said, and the publication was written about young people who have defibrillators after they presented with a cardiac event. And only about, I think 40% of them had an exercise test before the defibrillator was placed.
Yeah, fine.
And that's a problem in the system where the person wanting to put the defibrillator, they want the bed, they want to keep things moving, or there's money or impatience. So, I say slow down. So if you happen to be a parent and you're in the ICU and your child is there and someone's saying, we've got to get on and get the defibrillator, you ask the hard question. You say, what if we wait?
Yeah.
What if I go home with an automated external defibrillator till you guys are a bit more confident what you're dealing with?
We did that exactly 2 weeks ago, Shu. So that scenario, the family cardiac arrest at St. Elsewhere was going to get the defibrillator implanted pronto, because of course you do. He did cardiac arrest, no stress test. The family reached out and said, is this absolutely necessary? They actually got dismissed, AMA, against medical advice, because they got dismissed with a life vest. Came here, did the stress test, make the diagnosis of CPVT, and then we implemented a non-defibrillator treatment strategy. And so that slow down encouragement that you just gave is incredible. It's incredibly hard to do, isn't it? To try to slow down the freight train with these scenarios.
It's a little bit easier up here in the frozen north, but no, I'm kidding. The pressures on healthcare. Everybody's looking for that kid that looks like they could go home, and that's a pressure that vocal advocacy I think can help with. And the parents are much more powerful than you and me there. The parent can usually influence a surgeon or a schedule, but you and I, that's where half the hair is gone anyways.
Yeah. You mentioned how if we get the right treatments in place, they do great. And I want to bring that to one of your critical roles with creating and building the Pediatric CPVT Registry, and the lessons that we've learned together because of that spearhead of you and your team. Share a little bit about your thoughts as to when you said we really need to create a Pediatric CPVT Registry, global if possible, how that came about, and then I'm going to ask you what might be the one or two, three new observations that have come through that effort to build that kind of a registry. But tell us when this idea came to you, what motivated you to do this, how did you do it?
Yeah, thanks. I mean, it's the key word there is team, and I'm here representing a whole bunch of people. Some of them are on the papers, and some of them are behind the scenes. People like Danya and Sonia and Thomas Roston. So I really represent a team of people, and I'm very honored to be part of that. Now, probably about 10 years ago now, we had some success bringing collaborators together, and I was that was sort of my MO in the Pediatric EP Society. I would take a group of willing collaborators and say, why don't we see if we can learn more about this condition collectively? And we wrote some papers on some arrhythmias, and then we applied it to CPVT, and other people had the idea. And I certainly will not take credit for the collaborative nature of PACEs. I just sometimes was bossy enough or pushy enough that I just started the ball rolling and got things done. But Christina Miyake had done a wonderful, complicated paper on the pacemaker and ICD and CPVT. So it was already there. It just needed a bit of a push. And then grant funding is always a nice way to actually push a bit more effectively. So I had a few heart and stroke grants, and so that really helped. And it wasn't long before we were having those conversations. We have to mention Arthur Vilde, our mutual dear friend and mentor. And so it was just a natural relationship that we would say, okay, Arthur, you're building this very, you've got sort of the super centers in your registry, Mayo Clinic, Arthur's Amsterdam, Antoine. I'll represent the orphan centers, these little programs that have 2 or 3 cases, but they have enthusiastic collaborators, and they have the same questions. We all have the same questions. How can we do this better?
Right.
And so we have this, we have these parallel registries that are very much collaborative and working together. And that, I think, is the way to go. It's that, if you want to go far, you go together.
And in the pediatric CPVT registry that you lead, how many patients are enrolled right now?
So we have about 225, give or take, patients, and about 110 control. So an unaffected relative.
And the particular focus, we've mentioned the title of Pediatric CPVT Registry. So these are all children under 18, more or less?
Yeah, under 19 at diagnosis.
Yeah.
And, and right away you get into some tricky conversations because like your story, the child presents at 10 with typical CPVT, but doesn't get diagnosed till he's 19 when he finally meets the right person. And so, where is he actually a pediatric CPVT patient, or is he not? But these are sort of these are minor details. The important thing is to capture as much learning as we can, and we found some things. Some of it is good news. The overwhelming message is good news in terms of most of these people are doing very well once they're into the care umbrella, the right care umbrella.
And you think about maybe the last 5 years as you've been following and growing and building the registry, now with 225 individuals diagnosed before the age of 19. What maybe top 1, 2, 3 papers or lessons from those papers have been drawn because of the power of collaborating and building a cohort to be sized like that?
I think the I'll start with the opportunity paper that has not been written per se, but it comes out, and that's the opportunity to do better. So even within this fairly, the inner circle of people, the uptake of second line treatment. So the beta blockers are well used, but the second line, and whatever you call the second line, be it cardiac denervation, like you and Peter Schwartz have just published a nice opinion piece, fantastic work. Be it flecainide, whichever those are tracking at fairly low rates, 20%, maybe 25% for flecainide.
Yeah.
So that worries me, because in my clinic, almost everyone warrants one or the other. We have we'll go to flecainide, when the stress test is looking like we need to.
Right.
And
there, if I could interject there,
yeah,
Shu,
of course.
because you said flecainide, it struck me that opportunity cost, because yesterday's CPVT patient was told by their adult heart rhythm specialist, so not by their psychiatrist, that flecainide represented an end of the road therapy, quote, as opposed to right at the beginning combination therapy, which you and I would conclude the data would strongly encourage that this should be really close to upfront combination therapy. So, when we were kind of hard, or a little bit hard, on the front lines doctors for missing a warning feint, we have a lot of work to do within the community of electrophysiologists who CPVT is something that they almost never see in their world as well, to the point where they would then tell a patient adding flecainide represents end of the road, quote.
Yeah, I absolutely. I mean, and I would probably try and twist that person's words a little and say, end of the road, meaning you've arrived at the last, additional drug you need. But the era, I mean, the paper that changed things, really 2008. It didn't get a lot of attention, and the treatment hasn't gotten enough uptake. Now, we've gone into some other interesting directions. We've learned a bit about the neurodevelopmental challenges that some of these youngsters have.
Yeah.
That's it's probably complicated, polyfactorial. But again, by combining this, the whispers start becoming signal. And I hope that we can add to your activity paper that you guys put out, and I had the privilege of writing an editorial with Andrew Cron on that. And we're doing some work in the whole exercise space, because that's another one of these dogmatic pillars that's very hard to chop down. These kids are being benched right away. Once they have the diagnosis, it's very hard to get them to be allowed to be back into play. So,
and in our final, we have about 7 minutes on the counter. What research questions, you touched on it, the activity one and return to sport, but as you and maybe the rest of your team, whether it's clinical, translational, or all the way back to the bench, what kind of research questions do you feel are ripe for the asking and the answering that kind of excite you and your colleagues the most right now?
So one of the disadvantages of this format is I can't be writing on my dry erase board and drawing things, but certainly one circle is this area of stem cell and expressing some of these variants and understanding the whys. And why is one RYR ryanodine variant different? Are there modifiers or not? And you and I shared a poster at the heart rhythm meeting about whether Ackerman is or is not. Is it a red herring, or is it something of interest? So I enjoy that work, and there's not that many people doing work in that, because it's, it's very time consuming. You can only work on a few genetic types at a time. So I really enjoy that, and our scientists are learning with us. So I'm hoping that we can get to better treatments. Now that segues into, there are people, and you and I occasionally get to converse with them. There are people that want to develop better treatments, new molecules, and obviously a registry is the way to go, where you have the ability to find 50 patients that you could try these treatments on. So I mean, one can of course go to the the Mayo and the Amsterdam individually, but having these central repositories of patients who are generally engaged in what we're doing, I think is very helpful. So I think over the next, probably even next few years, we're going to see some new molecules that people want to understand and test. And then of course there's the whole, we still don't have the very basic, why did the event happen when it happened? You're born with a genetic condition. It's in you as a fetus. You present when you're 10 or when you're 18 on a Tuesday or a Thursday. What is going on? And those are those factors. And that's where I think we need, again, things like a registry to collect, AI, big data, and say, are there subtle fluctuations that we can't perceive on the individual level, but maybe once we get 1,000 CPVT events, we can understand them.
Yeah, I think the frustrations of the past are probably giving way to some really exciting opportunities for CPVT and long QT syndrome and the genetic heart conditions, where your program and our program will likely be enrolling patients in new drug trials for CPVT, probably early 2023, maybe even end 2022. So I think there's some really great news around the corner, and you've given some really encouraging news that, at least for our CPVT families who are plugged in, that when we make the diagnosis and when we get them on right treatments, they do great. I mean, they thrive, and it's a matter of getting them to that point where that warning feint is appropriately acted upon, so that the CPVT diagnosis, if there, can get uncovered and discovered, and then get them on the new beginning of which, from my forecast view, is a very positive new road once we get them correctly diagnosed and treated. Shu, I wonder, I've asked you at the beginning to get ready for one thing in the final goodbye, and this will be a mutual exchange of pictures, because you've had something really huge in your family recently take place. We've had something pretty huge in the Ackerman family. So let's do the mutual trade of photos in our final 2 minutes. So Shu's wife is a really talented person, a gifted photographer, and just did one of her first photography exhibits. And so I'll have him do a show and tell there. And then I'm going to do a show and tell to close. But before the show and tell, Shu, Dr. Sanatani, any final words that you would like to leave with everybody before we do the picture exchange?
Well, first of all, I want to thank you, not just personally as a dear friend, for engaging with me, but also for what you're doing for the inherited heart rhythm world. And it's a pleasure to watch. We get to see you on the podium pushing back the frontiers of ignorance. We get to see you challenging the dogma. You're putting yourself out here. You're 92 of these sessions. You're putting everything into it. I was so relieved when you on Twitter, I heard, well, finally you've gotten some help. Anyway, so thank you for what you're doing, and you and Alice and the SADS team are just tireless in your efforts, and what a resource. I'll tell you a funny anecdote from clinic the other day. One of one of my research team comes up to me with a stack of brochures, the SADS brochures on CPVT. And Dr. Sanatani, can we put these up in the clinic, please? And I said, have you read it? Have you made sure that everything in there is exactly what I would say? Anyway, so she comes back about 20 minutes later, said, Dr. Sanatani, you and Mike Ackerman wrote this brochure. So I said, well, all right, you can put it up then. So anyways, thank you for what you're doing. And to the families out there, please bring your questions and your passion. I saw the chat line was going, and a lot of them are very individual, but ask the hard questions to your specialist.
And now photo time, Shu, and thanks for taking the time. So this is,
I'm going to hit share, right? I guess.
Or if you have, well, that would be fancy if you can do that. I didn't know if you would just have it on your phone and then hold it in front of the camera. That's the fancy way.
No, I'm gonna try this. You should be seeing a tree.
If the tree is still Shu, then yes, we are seeing a tree.
Okay, well then, oh, you know what? Let's stop screen. So I am sharing, but maybe I'm sharing the wrong one. Let's try this again. I'll try one more time. Okay. So screen sharing easiest with 2 monitors. And then
it's good that this is free and we're not paying by the minute for our live program here as we end.
Oh my goodness. You're still seeing just me?
Yeah.
Oh
so
my
while
goodness.
she was trying, because there we go.
There we go.
Good job. So tell us a little bit about this.
So
your wife and her exhibit.
Yeah. So my dear wife of 28 years has been a photographer for even longer than she's been a very loving wife. But finally has done an exhibit. Now this is one of a series that she calls After Picasso. And it's so called because Picasso really wanted to see things from multiple dimensions, from all 3 dimensions. So this is probably about 20 superimposed takes of a tree from all different angles.
Wow.
And that's as much as I can explain. And so it looks, I mean, the screen doesn't do it justice, but it looks like an incredible portrayal of a tree with the lighting. And anyways, I was so proud of her to share her work. And thank you so much for acknowledging that.
That's great. Give her a big congrats. And as I leave everybody out there, this was last weekend. So our 3rd son, Jens, graduated from Baylor University, summa cum laude, mechanical engineering. And that was a special picture with the coach of the Baylor University National Championship men's basketball team that we took last Friday. And so that brings us to the end, everyone. Shu, thanks so much. I can't wait to have you on the program again. And in the meantime, for all of you out there, remember that our intention at SADS Foundation is for you to live and thrive despite your diagnosis. And so we wrap up CPVT Awareness Month, and we'll be back together for SADS Live number 93 on Friday, June 10th. So until then, be well, everyone.
Thanks so